大家好，我很高兴，今天我这个机会跟你们见面。不好意思，我的中文不太好，所以我用英文讲。如果我讲太快，请你们告诉我讲慢一点。Is this okay if I don't use a microphone? Can everybody hear me? Okay. Right. So I would like this to be a conversation, and so please, at any time, if you don't understand anything or you want to ask a question, interrupt. There's no need to wait till the end. I want to thank Dr. Chen and her colleagues for the opportunity to meet all of you today and present on this interesting topic. I'm looking forward to hearing your comments and hearing your perspectives on what's developing in the field. So I've already had a chance to talk to some colleagues here who are very aware of the developments in the psychedelic field, but from our trainees, the residents, and the medical students, can you raise your hand if you've been reading up on the literature or you're aware of psychedelics? So some. Okay, great.
Mostly junior.
Mostly junior psychiatrists. Okay.
Still watch a Netflix series about the micropolar.
That's right. I think in the United States, we have a lot of senior psychiatrists who are also interested because of the historical context, which I'll talk about. In the 60s and 70s, psychedelics were very popular. But amongst our trainees, our younger psychiatrists, this is a very hot topic for them to talk about. So we'll be talking about modern medicine's rediscovery psychedelics, the clinical use, some of the regulatory issues, and we'll go from there. So first, a little bit about myself. I work at the Greater Los Angeles VA and UCLA. So the Greater Los Angeles VA is our veterans hospital. So we only see veterans. I think it's a little bit different here in Taiwan, where your veteran hospitals can see both civilians and veterans. But in the U.S., we only see veterans. But I'm able to see patients on both sites, so it's a privilege to do so. In terms of what I do clinically, I am the director of the Interventional Psychiatry Service at the VA. So the services that we provide include RTMS, S-ketamine, ketamine, ECT, and then I also see patients with post-traumatic stress disorder or PTSD. In terms of my teaching responsibilities, I'm the director of our Mood Disorders Clinic, which focuses primarily on treatment-resistant depression, or TRD, and bipolar disorder. And I'm also an attending physician at the UCLA Psychosis Clinic, where I work with Dr. Stephen Martyr. On the research side, I have projects involving neuromodulation, or TMS, and also we have 2 studies starting up involving psychedelics. Outside my academic work, I've been part of the FDA's advisory committee for psychiatric drugs for the past 7 years, where our group helps the FDA review and provide commentary on new drugs that are being reviewed by the FDA for approval. So this is the outline of what I'll be talking about today. First, I'll highlight this recent interest in psychedelics, what we are calling the psychedelic renaissance. Some brief introduction on what are psychedelics, history of psychedelics specifically for the U.S. from the U.S. perspective, what is the treatment model currently being proposed. I'll go over a couple of landmark studies of the clinical trials and the data supporting the safety and efficacy of psychedelics. And then the regulatory considerations are more for U.S., for the FDA. And then finally conclude with an update on the current state of clinical development. So this is an article highlighting the number of other articles, talking about psychedelic therapy by year. And as you can see here, in the 60s and 70s, there was a small blip. And then after 1970, when psychedelics were outlawed, there wasn't much discussion about it. But then recently, there's been much more interest. And so many more peer-reviewed journals are publishing papers on psychedelic therapies. Of course, the main thrust has been from the general public. And so this book by Michael Pollan was published in 2018, How to Change Your Mind. And here he chronicled his experience using psilocybin, and then also he interviewed many people in the field who were pioneers of psychedelic therapy. Have any of you read this book?
We have Chinese translation.
Oh, perfect.
In
Good.
2020.
In 2020. Oh, good. And of course, with every good book that can make a lot of money, you need a Netflix. And probably more of you have seen this. I actually haven't seen this myself, but my understanding is it closely reflects what was discussed in the book. So, is this translated into Chinese?
Yeah, exactly.
Is it dubbed or is it subtitled?
There's also dubbed and subtitled.
Subtitled. Okay. Great. I'll have to watch that to practice my Chinese. Okay. And so there's probably not a week that goes by where there's not an article about psychedelics. So the New York Times is our premier newspaper in the U.S. And here are some articles from 2021 talking about psychedelic treatment. This is the New Yorker talking about DMT. A more recent article in the New York Times talking about psychedelics within the VA. So this is something that is of high interest amongst the veteran population. So not only is the general public and the scientific community very interested in psychedelics, but also our federal funding agencies. So these are our government agencies that help direct research direction and provide money for research. And so this is the NIH, the National Institutes of Health. They held a workshop in 2022 inviting major researchers to talk about psychedelics. The National Academies of Sciences, Engineering, Medicine, same year, several months after, also held a workshop on psychedelics. I was a panelist for this event. And then just earlier this year, the U.S. Department of Health and Human Services had a workshop about psychedelics. So we use the term psychedelics fairly broadly, and for those of you who are familiar with the term and the history, it's a little bit imprecise. So classical, we've now come to the use of classical versus non-classical psychedelics. And classical psychedelics, of course, are compounds such as psilocybin, LSD, and DMT. And I'll talk about that in a subsequent slide in terms of its mechanism. MDMA, which is likely to be the first compound approved, likely within the next year or so. This has been traditionally known as an empathogen or an entactogen, and not traditionally psychedelic. But we've really kind of grouped them into this under the same name. So now we differentiate by saying classical psychedelic and non-classical psychedelic. And of course, ketamine and S-ketamine has also been absorbed into the conversation, and so this is technically a dissociative anesthetic, but again, it falls under this non-classical psychedelic term. And my understanding is that here in Taiwan, S-ketamine has been in use for the last year or two. Some colleagues here have had some experience. Have any of you had the opportunity to treat patients with S-ketamine?
Yeah.
Okay, you have, and then Dr. Chen has. Okay.
We're combining biological and psychological.
Biological and psychological. So, in terms of mechanism and subjective effects, right? So LSD, DMT, psilocybin, these are all agonists at the serotonin 5-HT2A receptor. And the important part of the psychedelics is the acute subjective effect. So each of these have or can induce a very different experience for the patients. And so for the classical psychedelics, it's been described as inducing a mystical state or this sense of interconnectedness with the world around them. It's difficult to describe in words, and if you've never experienced it yourself. But patients have talked about they feel more connected with nature around them, with the people around them. It's just really something that has to be experienced. It's difficult to put into words. MDMA, a non-classical psychedelic, is a serotonin efflux or reverse transporter. So with your SSRIs, right, we block serotonin reuptake so that serotonin builds up in the synaptic cleft. What MDMA does, it not only blocks it, but it actually reverses the direction of serotonin. So then the presynaptic side actually spits out more serotonin into the synaptic cleft. And so the effects are fairly dramatic, and there's a very acute subjective effect. This is unlike SSRIs, where if a patient takes Prozac or fluoxetine or sertraline, they don't feel anything acutely. Right? They get better over the course of several weeks. With something like MDMA, where you're introducing a lot of serotonin very quickly into the synaptic cleft, there's acute subjective effects. And so here, the subjective effects are primarily pro-social. So patients talk about experiencing a sense of well-being, euphoria, and primarily a closeness to others, enhancing trust and empathy. And so that is one of the reasons why MDMA has been selected or used for the treatment of PTSD, because that is a disorder where patients have difficulty trusting other people. They feel that the world around them is very dangerous, and so trust is very difficult. But in treatment of PTSD, the relationship between the therapist and the patient is critical. It's critical in all types of psychotherapy, but even more so in PTSD. And so it's thought that these effects of MDMA help facilitate that conversation or the therapy. And then finally, ketamine, of course, is an NMDA receptor antagonist, and it induces a sense of dissociation. So patients feel as if they're out of their bodies. So very different from these two. And again, I think 5 years ago, nobody would have called ketamine or S-ketamine a psychedelic. But for a variety of reasons, it's been included in the conversation. So I won't talk about too much about this, but one of the challenges of running clinical trials for these drugs, especially randomized blinded clinical trials, is this what we call functional unblinding. Patients know what they got, right? It's pretty apparent to them if they got placebo versus active. And because of the expectancy of these drugs, they've read about what these drugs can potentially do, right? From How to Change Your Mind and all these news articles. And so when they come into the clinical trials, they're expecting a lot of good things, right? And because they pretty much know what they get because of these acute effects, that's feeding into a lot of the efficacy signal. And so that's one of the major challenges in the clinical trials field, is trying to disentangle that signal. Anybody have any questions about this? Okay. So I'm curious, in the United States, it's easy to get a hold of these compounds, even though they're illegal. So many patients will come to us telling us, oh, they've had experiences with these drugs. I'm imagining in Taiwan it's a little more challenging. But have any of your patients maybe done MDMA recreationally and come to you and just talked about that experience? A lot of patients.
At my clinic.
In your clinic, okay. So this is an article about actually a gastrointestinal doctor who participated as a subject in a psilocybin trial. And this just highlights the functional unblinding aspect of it. So this was only one dose of the medication, and he talks about it as the single most powerful experience of his life, right? And so you can imagine if a physician is saying this about a single dose of a drug, for our patients who are our subjects who are participating in the clinical trials, they're expecting a lot from the drug effect, right? And so it's we know this is contributing to the potentially placebo effect, but this really, when you hear people talk about their experiences in these trials, they're saying very similar things about the drug. Okay, so let's tell you a little bit about the historical context of these drugs, specifically from the Western or U.S. perspective. So psilocybin, DMT, many of these psychedelics that come from plants or from nature have been used for thousands of years. This is not something that's new. They've been primarily used in indigenous cultures. This is a cave painting from Algeria from, I think, 6,000 or 7,000 years ago. Charlie Grove likes to use this in his presentation. It's a picture of a medicine man, so the ancient equivalent of your cells, doctor physicians, right? And these little appendages covering this shaman, as they call them, are thought to be the mushrooms that psilocybin comes from. This mask that he's wearing is supposed to be a beehive, because back in the day, they used honey as a preservative. So it's thought that they were using honey to preserve these mushrooms. And they were used for a variety of purposes: sacramental uses, religious ceremonies, obviously some medicinal purposes, and also initiation rites. So these have been known and used and documented for thousands of years. In terms of the more recent Western history, some of the compounds, including MDMA and LSD, of course, are not from nature. These have been synthesized. So MDMA was synthesized back in 1912 by Merck Pharmaceuticals. The compound that they were making was initially a weight loss drug or stimulant. MDMA was an intermediate metabolite. So MDMA was not the purpose of the synthesis, but it was just a compound in the middle of making the stimulant. This is apparently the patent for that compound in German. 1938, of course, Albert Hofmann is known as the father of LSD. He was trying to synthesize a variety of compounds, and LSD, as we know it today, was the 25th, so it was LSD 25. It wasn't until several years later that he realized the psychological or subjective effects of LSD. So he synthesized it in 1938, but didn't know what it did. Several years later, if you maybe know the story, he tasted some himself and rode his bike home and had this very intense psychedelic experience that he writes about. May of 1957, an article was published in Life magazine. So Life magazine, back in the day, was a very popular magazine for the general public. And here, Gordon and Valentina Wasson, he was an amateur mycologist. His hobby was to collect and look at mushrooms. And he and his wife went down to Mexico and met this woman, Marina Sabina, who introduced them to a indigenous practice called the velada, which involved the use of psilocybin. And he ingested psilocybin, and he wrote about it, and this was published in Life magazine in 1957. So this is one of the first times the general public was introduced to this idea of psychedelic compounds and its potential effects. So unfortunately, in the U.S., the history is not all good. There's a dark side to it. So you guys know about the CIA?
Yeah.
So it's our spy agency. So they had a project called MK-Ultra where they were trying to use psychedelics for mind control. So they're trying to brainwash people, change their minds, do a variety of things. And they were giving these compounds to people without their knowledge. So not following the current protocols that we have for clinical trials. There were several bad outcomes, including one where it's thought that they dosed one of their employees unknowingly to the employee, and he jumped out the window of a building several days later, and it's thought that it may have been due to the effects of the LSD. Psychedelics at that time, the 1960s, were associated with the counterculture, so a very kind of anti-government movement. This was during the Vietnam War, where there were many protests against what the U.S. was doing in Vietnam, and psychedelics was heavily used or prevalent or associated with that movement. And for that reason, and some others, including some of these bad outcomes, the U.S. government outlawed psychedelics in 1970 with the Drug Act of 1970. So prior to 1970, these drugs were actually legal, but then after 1970, they were made illegal. And so much of the research stopped. All the clinical work, of course, stopped. And there was a quiet period for the next 50 years or so. Now, even though it was outlawed in 1970, there continued to be a lot of underground use. So many therapists and physicians would use it illicitly for their patients, for therapeutic purposes, but again, what we call underground. And the MAPS, for those of you who know about, you know about MAPS. Does anybody else know about MAPS? The Multidisciplinary Association for Psychedelic Studies. So MAPS is the organization that has been running the clinical trials for MDMA. So they're actually not a company. They were actually originally a group of therapists, practitioners who were using psychedelics in the underground, and they formed this organization. And they've been around for this long, and to their credit, they got enough money and funding and organization to start the clinical trials for MDMA. So if MDMA becomes approved by the FDA, this will be the first drug approved by the FDA, not sponsored by a major pharmaceutical company. So let's talk a little bit about the therapeutic potential, specifically the treatment model in which psychedelics are currently being proposed, and then look at some of the clinical studies, the data supporting their efficacy. So in terms of the treatment model, this is an integration of medicine and therapy. So when your patients come to you with depression, they ask you, doctor, should I do psychotherapy or should I do medicine? What do you usually tell them? For some of our trainees, what do you tell them? Is one better than the other? Or is doing both better than just doing one?
Of course.
Right, both, right? So the data clearly shows that medicine, medication versus psychotherapy, they're about equal efficacy. But doing both, you get better outcomes. But when patients do that, there's really not an integration between the two, meaning that you as a doctor will prescribe the sertraline, right, or the fluoxetine, and then the patient goes to their therapist and has their weekly psychotherapy. But there's really not I would say, coordination between the two. You're doing the two, and you're probably doing both at the same time. But beyond that, I would argue that there's not really an integration. But here, in this current psychedelic model, as I'll talk about, there is a much closer integration. Those two are, some would say, inextricable, and you can't pull those two things apart. So, in its current model, we're calling it psychedelic-assisted therapy. Right? And the medicine component, of course, here, the ones that are furthest along in development are MDMA and psilocybin. And the non-medicine component is the psychotherapy, or depending on which model you're looking at, some of it's called psychological support. So one important aspect for the psychedelic-assisted therapies is this idea of set and setting. Right? Set is referring to mindset. What is the patient thinking about before they enter the drug experience? What are the things that you hope to bring up? And these things include expectations and understanding. What do they expect from the drug experience? What is their understanding of what that drug experience will feel like? What is your intention? What do they hope to gain from the treatment? Right? There's also discussion about patient values and priorities, understanding where your patient is coming from, and then also asking your patient to think about memories, traumas, relationships, things that they may believe to be important as far as what's affecting their lives, what's contributing to their distress, what's contributing to their psychiatric diagnoses. The other part of it is the setting. So setting refers to the physical environment where these drugs are administered. So you can see here, this is a typical psychedelic dosing room. It looks nothing like the doctor's office, right? So I was showing this slide to my daughter, 6 years old, and she said, "Whose house is that?" It's like, "Oh, that's not a house. That's actually the doctor's office." She's like, "Oh, why doesn't it look like the doctor's office?" I say, "Exactly. It's not supposed to look like a doctor's office because you want your patient to feel as comfortable as possible. You don't want it to appear to look like a clinic." So I asked her, "What do you when you go to a doctor's office, what comes to mind for you?" She said, "Oh, they're going to give me a shot. It makes me very anxious." I mean, exactly. Right? Usually when people go to doctor's offices, they're not doing well, right? They get anxious. And so you want to do the opposite of that. You want to make them feel as home and as comfortable as possible. So that's why it looks like somebody's living room. It's supposed to be inviting. You want the patient to feel safe, right? And oftentimes there's music played throughout the entire drug experience. The safety part's big because some of these drugs, especially the classical psychedelics such as psilocybin LSD, can cause a significant amount of anxiety in the patient. And so you don't want anything else adding to that anxiety. So I think this is maybe the most important slide as far as how this current treatment model works. And this is really the integration of therapy with the drug. So there are three main elements or phases in this psychedelic assisted therapy model. So first is the preparatory sessions. This can take between 1 or 6 hours over the course of 1 to 3 sessions. So 3 kind of standard visits. And here, it's the mindset that you're getting the patient ready for, right? One of the things you're doing is preparing the patient for the drug experience, telling them what this might feel like for you. But number 2, all those things I mentioned before about asking the patient, what's your intention for this treatment? What are the memories that keep coming up for you? What are the relationships or the traumas you feel need resolving? So you want to bring all those things up during these preparation sessions. And then you go to your medicine session. And this lasts between 6 to 8 hours. So you're in the room with the patient for 6 to 8 hours. That's not our current psychiatric model, right? We're in the room with the patient an hour maybe. So here we're asking the therapist to be in the room with the patient for 6 to 8 hours because that's the duration of some of these drugs at this point. The therapists are there to act as guides. So unlike cognitive behavioral therapy or CBT, this is a very non-directed approach. So for CBT, we're often telling the patient what to think about, what to do next. Here, it's really about the patient leading the experience. So it's often called an inner-directed or non-directed therapy. The other aspect of it that I won't talk about too much today is that the FDA has required for our clinical trials 2 therapists to be in the room with the patient. So it's not a one-on-one, right? And it's primarily for patient safety purposes. So now you have 2 therapists sitting in the room with the patient for 6 to 8 hours. And that contributes to what I'll talk about at the end is some of the challenges, which includes the cost of these drugs. And so in the United States, the drug, it's going to cost some money, but the primary cost component will be the time of 2 therapists with the patient. And then after your single drug therapy session, then you have your integration sessions. And these look a little bit more like your traditional psychotherapy sessions. Here, there's no drug involved. The patient is meeting with the therapist again to talk about what memories, what things came up for them during the drug session, and how to integrate those ideas. Why did it come up for you? How did you make sense of what came up for you during that drug experience? Any questions about this? So you can see here that the therapy and the drug are really kind of intertwined, right? Very different from how we currently practice psychiatry, where we give the drug and then send them away for therapy. These 2 things are, again, some would argue you can't pull them apart. They have to coexist with each other. So let's go over some of the clinical studies that has really sparked the interest in our field and amongst researchers. So this was one of the first modern trials. Of course, back in the 60s and 70s, there were some clinical trials, but they didn't use modern techniques. Right? So this is one of the first ones using a modern clinical trial design. So this is from Robin Carter Harris. At that time, he was at Imperial College London. He's now at UCSF, University of California, San Francisco. In this study, this was a study of patients with treatment-resistant depression, and this was an open-label trial. So everybody knew they were getting psilocybin. And they got 2 doses, 10 milligrams and 25 milligrams, and they had 20 subjects included in the study, and they looked at outcomes 1 week, 3 months, up to 6 months after the last administration of psilocybin. So these are the results. On the y-axis is the QIDS score. So the QIDS is the scale that we use to assess the severity of depression. So the higher the number, the more severe the depression is. So you want lower numbers. And then on the x-axis is time points. So baseline is before they got any treatment. And this is 1 week, 2 weeks, 3 weeks, up to 3 months after they got treatment. Here, of course, these are the p-values citing statistical significance. And then this is Hedges G. So this is the effect size of the treatment. For our trainees, do you have a sense of what's the average effect size of our antidepressants for depression? Is it bigger than 1 or lower than 1? It's lower than 1, right? It's like 0.3, which is a small to medium effect size, right? Good treatments are like 0.5, maybe 0.6. We rarely see in medicine anything approaching an effect size of 1. Here, you've got effect sizes of 3, right? So this is massive. This is unheard of, right? And so this is one of the reasons why people were so excited about these treatments, is that you saw these massive effect sizes. And so here, and the other thing is, they're seeing these effects 1 week after their last dose of psilocybin. When you put your patients on an SSRI and they ask you, doctor, how long will this take to work? What do you usually tell them?
2 weeks.
Yeah, maybe you start to feel an effect at 2 weeks. Maximum effect, 6 to 8 weeks, right? But here, you're seeing a massive effect at 1 week. So potentially very rapid acting. And then also 3 months out. So remember, they only got 2 doses and that's it. And 3 months out, you still see an effect size of 2. So the other aspect about psychedelics that people are excited about is the durability. How long do these effects last? Right? With our current treatments, when the patients ask you, well, doctor, after I feel better, how long do I have to stay on my medication? What do you usually tell them? Can you stop? Do you need to stay on it? Or it depends? It depends, right? So the answer, so for our trainees, right, the answer for any question in medicine is it depends. So if it's their first time for depression, their first depression, you can probably come off of it 9 months to a year after you get better, right? But if they have recurrent depression, if they have treatment-resistant depression, they probably need to stay on the medication for the duration of the lifetime to stay better, right? We're not curing anything in medicine, unfortunately. We're just managing the symptoms. And I'm not ready to call this a cure yet. Nobody is ready to call it a cure yet. But this is maybe the closest thing we have to it, especially when it lasts that long after a single treatment or after 2 treatments. So that was for psilocybin, and this is for MDMA. So MDMA-assisted therapy for PTSD. These are the results from 2 phase 3 trials. From the MAPS organization. And notice that these are published in Nature Medicine. So we don't have, not many psychiatric trials or studies are published in such high-profile journals. So the fact that they're in Nature Medicine tells you that people are taking interest in these compounds. So this one was published in 2021, and this was earlier this year in 2023. So here it's MDMA-assisted therapy for severe PTSD. Again, randomized, double-blind, placebo-controlled phase 3 studies. And these are the studies that the MAPS organization has submitted to the FDA for consideration for approval. So in the United States, you need at least 2 positive phase 3 trials for the FDA to even consider approving your drug. And they ran 2, and they got 2 positive, which is pretty good. So this is the results from the first phase 3 trial. This is published in 2021. On the y-axis is their CAPS-5 score. So CAPS-5 is an instrument that we use to, again, assess severity of PTSD symptoms. The higher the score, the more severe their symptoms. On the x-axis is the different time points. At the first time point, this is baseline, so before they got treatment. And they got a total of 3 MDMA treatments, separated by a month. So after the first session, they looked at their scores. After the second session, they looked at their scores. And after the third session, they looked at their scores. So in between these sessions, there's about a month. And this is where the integration sessions are going on. So session 1, they got their first dose of MDMA. and then they got 3 integration sessions, and then they got their second dose of MDMA, and they got their integration sessions, and then the third dose of MDMA, followed by 3 integration sessions. In the red, so you got 2 groups. You have the active group, which received MDMA, and then you got your placebo group, which received an inert compound, or inert pill. Both groups received the psychotherapy, this inner-directed psychotherapy. So at no time was anybody in the trial not receiving any type of treatment. Both groups received the same psychotherapy, but then one got the MDMA and one did not. So the one that got the MDMA is in red, and the one that just got the psychotherapy is in blue. And as you can see here, there's a separation at the final endpoint at time 3. And this is an effect size of 0.97. So not as big as the psilocybin trials, right? But the psilocybin trials were open label. Everybody knew what they were getting. Here, it was 50-50, right? And so the expectancy component of it is being controlled for a little bit, right? But probably most people who got MDMA knew they got MDMA. Now, there are some examples of people who did not get MDMA who actually thought they did, and vice versa. But 80 to 90% of people who got MDMA guessed correctly. Yes? Yes? To get MDMA? Yeah, great, fantastic question. So in terms of the inclusion-exclusion criteria, for this study, I believe they could have used MDMA previously in their lifetime, so illicitly or illegally, but they could not have used it more than 10 times within the last year. So some of these patients knew what it felt like, right, because they used it before, and some patients did not. Now, the doses that they use recreationally and medicinally are a little bit different. So potentially they may have used much larger doses when they're using it for recreational purposes. Right? But these medicinal doses were designed to elicit a very clear subjective effect. Excellent question. Any more questions about the design of this? I'm not spending too much time on it, but if you're obviously happy to comment on how these trials were designed. So these were the results from the second phase 3 trial. This was published earlier this year. Again, CAPS scores on the y-axis, and then different time points on the x-axis. In the red is the group that got the active MDMA, and the blue is just the therapy alone with no active drug. You can see here still a clear separation between the 2 groups. Their scores are much lower with the active group. The effect size is 0.7, so not quite as large, but still very good, right? Again, SSRI is like 0.3. This is like more than double the size. So one question I often hear about is, well, how long do these effects last? So they are following these patients up long term, up to a year, I believe. They have not published that in a peer-reviewed journal yet. However, they have discussed it at conferences and poster presentations. What I've heard last is at a year out, maybe 25% of these subjects are still in remission, right? So after these 3 doses, 1 year out, they didn't receive any other treatment, and their PTSD is still in remission. 25%, not everybody, right? So patients relapse, right? But to have that durability in that large number of folks is pretty good. So those graphs showed their improvements on the symptom severity scales. Of course, we're not just interested in patients having less symptoms. We want our patients to function better. Right? Ultimately, we want them to live better lives. And symptoms don't necessarily always correlate with that. And so we have scales that also look at their ability to function. The Sheehan Disability Scale, or SDS, is one such scale. And here they also show that the patients who receive active MDMA plus psychotherapy are functioning better than the patients who just got the psychotherapy alone. Any questions about the MDMA trials? So those are our most or furthest along in terms of development, and as I'll talk about later, likely because of the results that I just showed you, MDMA will probably be the first psychedelic, non-classical psychedelic that's approved by the US FDA. This was published late last year. psilocybin for treatment of resistant depression, so a single dose. And this was a New England Journal of Medicine, so another very high-profile journal. And this is, of course, from Compass Pathways, which is the company developing psilocybin for depression. So let me orient you to this graph. On the y-axis is the decrease in their MADRS score. So the MADRS is the Montgomery-Åsberg depression rating scale. It's what we use to quantify how severe the depression is. And so here, the further you go down, it means they're improving, their depression is improving at a higher degree. So in terms of the three lines, the gray line is the patients who received 1 milligram of psilocybin. So this is thought to be an inactive dose. It should not induce any subjective effects. And so this is being used as the quote-unquote placebo. And then in the green line is the 10 milligram dose, which is a middle dose. And then in the blue is the 25 milligrams, the full quote-unquote psychedelic dose. Their primary outcome was at 3 weeks, but they looked out to 12 weeks. So you can see here at their primary outcome of 3 weeks, there's a clear separation between the 25 milligram arm and the 1 milligram arm. And the difference there is 6 points between the blue and the gray. So this is in a population of treatment-resistant patients on the MADRS scale. So do you guys have a sense of currently approved treatments for treatment-resistant depression, such as Abilify or quetiapine? What is the average difference in or change in their MADRS scores that have been from the phase 3 clinical trials? How much do patients generally get better? Anybody have a sense? It's like 2 to 3 points. So it's not super impressive, right? But these are drugs that have already been approved. So here they're improving 6 points, which is about twice as large, right? Fairly impressive. So we see a statistical significance here, and then the patient, this is a single dose, and then they follow them out, and then at week 12, you can see that the group who received the 25 milligram dose looks like they're still doing better than the 1 milligram dose. And for those of you who are familiar with this article, there's actually not a statistical separation here. But you know, if you ask Guy Goodwin, he's the chief medical officer, he'll tell you, well, it's because they were not powered to detect that difference, meaning that if you had more patients, you would have had a statistical separation. But it does look promising that at least 3 months out from a single dose, that patients are still showing notable clinical improvement. Any questions about the clinical trials, the data that I went over? Yes?
So is MDMA also show those effects?
For depression? Yeah, so MDMA, they also looked at depression scores in, I believe they used the Beck Depression Inventory, and they do show an improvement in depression. But these are in PTSD patients. So I am not aware of any late phase clinical trials using MDMA specifically for depression. But when they looked at depression as a secondary outcome in PTSD patients, because depression is very common in PTSD, their depression is also improving. But it wasn't a primary outcome. So difficult to say that if you used MDMA in a primarily depressed population, would you have the same effect? I would say you probably would, but I think the trials have yet to be run.
And there are improvements in eating disorder and addiction.
Yeah, so the MDMA is also being looked at for eating disorders, addiction, anything, you name it, they're looking at it at this point.
Sorry.
Yes?
Why did the trial use the 1 milligram of this drug for comparative, but not pure placebo?
But placebo. That's a great question. So when the patients are, expectancy. So when the patients were recruited for the study, they said, you're going to receive psilocybin, right? They don't tell you how much there is. but we guarantee you're going to receive psilocybin, right? And so that captures part of the expectancy. So these patients, so one of the big problems for these trials is every patient who comes in, or every subject who comes in, has read about psilocybin. They know that there's this potential to make these huge effects, right? So if you tell patients you may not get it, there may be have you heard of nocebo effect, right? So if they think that, oh, there's a possibility I might not get it, and then they don't feel anything, they may say, oh, I didn't get it. And their depression actually may get worse because of it. But if you use 3 doses, and you tell all the subjects you're going to get psilocybin, you're controlling for a little bit of that expectancy. That makes sense? Yeah, that's a great question.
Like,
yes?
Because the psilocybin effect is so strong and so intense, it's hard to do the double blind.
Yeah.
So is it possible to do the double blind like even other kind of
psychoactive compounds? Yeah, people have been looking at that. So for our MDMA study that we're running at the VA, we're actually comparing it to amphetamine. So I don't think you have Adderall here in Taiwan, right? Yeah. So amphetamine is used as an ADHD drug in the United States. It has pretty acute effects. It's not the same as MDMA, but we're using that to help with the blind. So people have been looking at using other psychoactive compounds, but as you know, nothing quite recapitulates that subjective effect, right? But there have been some studies using some psychoactive compounds. Yes?
These treatments are all mostly for TRD, like consideration or as a first-line treatment?
Yeah, great question. So, as I'll talk about, I didn't put up the data here, but USONA Institute, who's also looking at psilocybin, they're looking at it for first-line treatment of major depression. And actually, we're going to be one of the sites for one of their phase 3 trials. And their phase 2 data looks very good because they were looking at it in a non-treatment resistant population. So that study was published earlier this year. I can't remember do you remember which journal it was? Was it Lancet, maybe?
Yeah.
It might have been Lancet. So that's out. It's a phase 2 trial, single dose of psilocybin for major depressive disorder, not treatment resistant. Charles Raison, I think, was the first author on that one.
And they recruited about 100 subjects.
Yeah, about 100 subjects.
Yeah.
About 15% had TRD, but the majority did not have TRD. Yeah. So let's finish up with some regulatory considerations. Again, this is primarily for U.S. FDA. So the FDA approves new human drugs, biological products, it approves food additives, it clears medical devices. So in order for you to commercialize a drug and say it works for depression or works for schizophrenia, you need the FDA to clear it. You can't just make that statement, right? And if your drug is cleared for depression but not schizophrenia, you can't make that claim, even if some of the clinical trial data suggests that it is. So it's fairly regulated. What the FDA does not regulate is the practice of medicine, right? So what does that mean? So I'm assuming you're able to prescribe medications off-label here, right? And we do that all the time, especially in psychiatry. And that's considered the practice of medicine, right? It's something that the FDA has not endorsed, but because the drug is generally safe and on the market, you can, as a physician, you have the right to make that decision. Non-drug, non-device interventions, such as psychotherapy, right? That's not something the FDA regulates. Right? They can't control, they can't tell you what you can or can't say in your psychotherapy session. So with this integration of medicine and therapy, you have a regulated component and you have an unregulated component. So how is that going to work? So that's the $1 billion, some people say $1 million, but this industry is probably going to be maybe $1 billion. So that's the $1 billion question. And I don't go through it in detail here, but there's a couple of mechanisms that the people think the FDA will use. If you're familiar with the REMS, which stands for Risk Evaluation Mitigation Strategy, that's a program that the FDA can implement if they feel a drug has some potential risks. So in the U.S., clozapine, when you prescribe it, the patients have to get a blood draw before they start, and they have to get blood draws every month afterwards. If you don't get the blood draw, you can't get the drug, right? And so the REMS makes you do that. So many people think that they'll implement a REMS here to force you to do the therapy with the medicine. Because if they don't, they can say that in the label, oh, you should do the medicine with the therapy. But if there's no way to mandate that, then physicians can just prescribe the drug and not do the therapy, right? But there's good reason to believe that there may be enough risk involved such that you want both together. So the incorporation or integration of drug and a non-drug component is not a new phenomenon. In fact, there's several drugs already on the market where the drug label recommends that you do drug with a therapy. So for example, disulfiram, antabuse, this is used for alcohol use disorder. Disulfiram is an aid that should be used with supportive and psychotherapeutic treatment. Right? If you use a drug alone without the supportive therapy, it may not work. Right? So that's what the label says. But you don't have to do the psychotherapy with it. You can just prescribe the drug. Right? But the label says you should probably do both for it to work. Naltrexone, also used for alcohol dependence and opioid dependence. Again, Vivitrol, it should be part of a comprehensive management program that includes psychosocial support, right? Basically telling you, don't just use the drug alone, you need to do it with something else. But again, because they don't force you to do the psychosocial part, you can just do the drug by itself, and that's completely legal, completely fine, and that's done all the time. So I talked a lot about the efficacy and the promise and the excitement surrounding this, but obviously there are potential harms. Are any of you familiar with what happened with this pilot? Yeah. So this was just in October. So this is an airline pilot for a commercial airline, and he wasn't flying the plane at the time, but he was going from one airport to the other. And oftentimes in the U.S., when commercial airline pilots are moving from one location to the other, they'll just jump on the plane of an airline and they'll give them a ride. And sometimes, if there's not enough space, they'll have them ride in the cockpit with the actual pilots. And so this pilot, who was not flying the plane, was riding in the cockpit with the pilots, and there was 80 passengers in the plane. And in the middle of the flight, this plane was already a couple thousand feet in the air, he got up and tried to shut off the engines. Right? Tried to shut off the engines of the plane. Fortunately, the other pilots stopped him, and he was able to. And they got him out of the cockpit, and they put him in a seat, and they strapped his arms down, and then he tried to get up to open the exit, the emergency exit of the plane, while still mid-flight. And so they landed the plane early, and the police arrested him. So this pilot, what had happened was he was suffering from depression, and 2 days earlier had taken psilocybin, not part of a clinical trial, but taken psilocybin on his own. When he was on the flight, he reported that he thought he was still in a dream, and that by pulling the handles to shut off the engines, that he would be able to get out of his dream. Right? So this is not an uncommon phenomenon. You hear patients talk about, I feel like I'm still in a dream state. Right? And this is 2 days after he took the psilocybin. The psilocybin was out of his system. The acute effects were over. Right? But patients sometimes, in 1 week or 2 weeks after using psilocybin, can feel that altered state. And that's not uncommon. So you can imagine, if he had the proper preparation in maybe a clinical trial setting, this might not have happened. To say that, hey, after you have your drug experience, you may still feel a little bit altered. This is completely normal. If you feel altered, give us a call, do something, right? But here, he took drug on his own, and he almost killed 80 people. Right? You guys know, of course, Matthew Perry unfortunately died earlier this month, and this article just came out 2 weeks ago. So when they did the autopsy, they found high levels of ketamine in his tissue. So it's known that he was actually doing IV ketamine infusions for treatment of depression. So in the United States, we use IV ketamine for treatment of depression as off-label. And there are actually a lot of private clinics especially in Los Angeles where I live and then in San Francisco, because it's a big money maker. One infusion you can charge $600 cash. That's American dollars, right? And so he was getting these infusions, but he had his last infusion apparently was, I think, a week or a month prior to when he died. And so it's thought that he probably was potentially ingesting or using intranasally, and that's why he had such a high level in his blood. Because ketamine is out of your system in a couple of hours. It's fairly short acting. So it certainly could not have been from the IV. And even though they talk about that he died from the ketamine, he likely lost consciousness and drowned in the hot tub. Because to die from just ketamine alone is actually very rare. It's actually a very safe anesthetic. And anesthesiologists, that's why they like to use it. Because instead of lowering your blood pressure or lowering your cardiovascular tone, it actually increases it. So they like to use it for kids and pregnant women. There was a recent meta-analysis looking at ketamine deaths, associated deaths. Almost all of them had other drugs involved. There were only about 2 that they thought were due to ketamine alone. So it's actually very safe. But again, used unsupervised, you can imagine bad things can happen. So let's finish up with the current state of clinical development. As I mentioned, MAPS, this Multidisciplinary Association for Psychedelic Studies, has been running the clinical trials for MDMA for PTSD. They have received FDA breakthrough therapy status for PTSD. There are the 2 positive phase 3 trials that I described a little bit earlier. And actually, just earlier this month, they submitted their package to the FDA for consideration. So the FDA now has 60 days to decide whether they will accept the application for formal review. If they do, within the next 6 to 10 months, they'll make a decision about whether to approve or disapprove MDMA-assisted therapy for PTSD. So people are keeping their fingers crossed, but if everything goes smoothly, we may get our first non-classical psychedelic approved in 2024. Compass Pathways, this is the company responsible or looking at the use of psilocybin for treatment of resistant depression. There is currently 2 active phase 3 trials. So they're recruiting right now, running those trials for TRD. And to your question a little bit earlier about use of psilocybin for just regular depression, UCLA Institute. So this is a non-profit organization that was founded by Bill Litton. Do you guys, anybody work in the lab here, use reagents? Any bench researchers here? So Promega is a lab reagent maker, and Bill Litton founded that company, so he's a billionaire. And he has a very personal interest in psychedelics. And so he founded the UCLA Institute, and they have been studying psilocybin for regular MDD, not TRD, and they're starting their phase 3 multi-site studies now. A good friend of mine from Residency is their chief medical officer, and so he's invited us to be one of the sites for that at the West Los Angeles VA. So open questions in the field, this idea of functional unblinding and how much of that is contributing to efficacy signal, right? How much of it is it actually the drug, and how much of it is just the patient hoping the drug will get them better, right? Again, the durability of effects. How long do these things last, right? This is not a cheap treatment. So for the MDMA-assisted therapy treatment, a cost-effectiveness study was, or analysis was run. It's about $15,000. In medicine, that's not a lot of money, but for psychiatry, it is, right? And so if it's going to cost that much, how long will the benefits last, right? So that's a big thing. Issues of cost and access to treatment. Insurance companies, if you have to go through your insurance, they will probably not pay for these things as first-line treatment. They'll probably require you to fail first, second, third line treatment before they say, okay, we're going to shell out the $15,000 for treatment of your PTSD using MDMA. And as I talked about in the regulatory component of the presentation, how will psychedelic therapies be approved and regulated, right? How will that therapy part be incorporated, mandated as part of the treatment package? Well, thank you very much for your attention, and happy to take questions.
Any questions from the audience?
Yes. I'm kind of curious, in the clinical trial setting, you say the FDA that you should have two therapists at the scene.
Yes.
And I wonder what's the role between the two therapists.
Yeah.
And also another question is that if the subject have a bad trip, how do you deal with that?
Yeah, great question. So in the MDMA model, both therapists are thought to be equals. They're both, participating in the therapy with the patient. In the Compass model, they have the main therapist who's driving most of the interaction, and then you have the kind of assistant therapist who can be of a lower qualification. There's a variety of reasons for that. For the Compass model, they actually don't even call it therapy. They call it psychological support. And so they don't want to call it therapy. They know their goal as a drug company is to sell as much drug as possible. That's how they make money, right? It's going to be very difficult to sell the therapy, and they know the therapy requirement is going to be the bottleneck. So they want to minimize as much, they want to lower the barrier for that psychotherapy, psychological support model. So what they're actually looking at is, can you have a room where you have therapists in all the rooms with the patient, but then you have the second person able to view 4 or 5 rooms at the same time. So what they're trying to do is minimize the amount of manpower, woman power, person power required as part of that therapy package. So in the Compass model, it's one therapist driving most of the interaction. In the MDMA model, both of them are quote-unquote equals. In terms of the bad trip, so yeah, it's an outstanding question. So that's one of the reasons why you have 2 people. That's one of the main reasons why you have the preparation sessions. To tell the patient, to prepare the patient ahead of time. You may have a difficult experience. If you do, right, this is time limited, right? People talk about, I thought I was going to die when I was, in the session, right? And you can imagine people get very distressed and very anxious and they want to leave. So if you prepare the patient enough ahead of time, hopefully you'll be able to mitigate the severity and maybe the incidences of those bad trips. I haven't seen it myself, but there is a documentary out on Netflix from, I think, that first psilocybin trial with Robin Carter Harris, where the patient actually gets up and tries to leave. And so the therapists were doing their best, and fortunately they did not leave, but they were doing their best to calm the patient down and calm them down. So to my knowledge, there have not been any incidences where there's physical restraints have been required. But the patients or the subjects that have been recruited for these studies have been very, very carefully screened. So anybody with a history of psychosis is excluded from these studies. They've even excluded people with a family history of psychosis, which is actually very conservative. So if you have any first-degree relative with schizophrenia, they won't allow them to be part of the trial because there is the potential, especially for psilocybin and MDMA, to elicit a psychotic experience. You can imagine if patients become psychotic during the medicine sessions, it may be very difficult to calm them down. Does that answer your question?
Yeah. Yeah, we didn't have the renaissance of everything because at the beginning we didn't have experienced the 50s and 60s.
Yeah.
We didn't experience the Professor Leary's
Yes.
era.
Yes.
So
Yes.
we're kind of like a very clean background.
Yes. Yes.
In Taiwan, we will say even though there's drug problem, but
Mhm.
it's quite relatively very clean in our street rather than San Francisco and Bay Area. So I feel like it's a very, very new development. It's like a virgin back here.
Yes. Yes.
So we can try everything if there is evidence basis, and I feel like it's very promising here.
Yeah.
So, but I also think because you have mentioned that there's a long history of a cultural context in the United States to develop psilocybin, even from the Mexico, even from the other regions. So we didn't have such a culture.
Yeah.
So it's kind of like from our
So we have to depend on ourselves.
Yeah.
Junior
psychiatrists.
Yeah.
Collective
Yeah.
to propagate.
That's a really interesting point because I think with the history in the U.S., there's 2 sides of the coin, right? We have the experience that if we go too quickly, if we're reckless about it, bad things can happen and they can potentially get shut down. So right now in the psychedelic field, there's 2 camps. One camp is saying we need to go as quickly as possible and make this available to everybody, right? The other side is saying we need to go step by step, systematically, go through the proper channels, get this FDA approved, and this will be a legitimate medical treatment, right? And there's tension between the two, because one wants to go really quickly and one wants to be very conservative. And because of our history, we know that if we go too quickly, bad things will happen, right? Anything that can help, one of the things I tell my residents, anything that can help you can hurt you, right? There's no free lunch in medicine, right? And so, this is not going to work for everybody. This is not going to be appropriate for everybody. But some people in the camp that want to go really, really quickly believe it can cure the world, right? And I think they can help a lot of people, but a lot of bad outcomes may occur. And so you need to have a balance, right? So that history is kind of a plus and minus. So interestingly, from the 50s and 60s, there's all the people who lived through that time are starting to retire from medicine, right? Kind of the younger generation, we have some awareness of the 50s and 60s, but not that much. But there is a literature to read about, and we can talk about people who lived through the time. But we ourselves never lived through it, right? So we're a little bit removed from it, but it's a very romantic idea that we have, right? So it's interesting. I think it some of it helps, and some of it can inform, and some of it is potentially detrimental.
Any other questions? Okay. Dr. Singh? I have two questions. Maybe they have some relation. The first one is, what kind of psychotherapy is used when combination with psychedelics? Because actually we are not very familiar with it. And the second question, is there any research on combined use psychedelics with hypnosis?
Yes. Okay. Great question. So first question is about what type of psychotherapy is being incorporated or combined with these psychedelics. Because there's not much awareness of it here. There's not much awareness in the U.S. because the model that they're using is not something that is generally taught, right? It's for the MDMA-assisted therapy, the MAPS model, as they call it, it's something they developed on their own, and they describe it as this inner-directed therapy where you're really letting the patient and the patient's experience with the drug drive the psychotherapy interaction. So it's very non-directive, very unlike CBT. It probably looks more psychodynamic, right? Maybe more even psychoanalytic, right? So what it looks like kind of in practice is you have the patient there, they're laying there, they're undergoing the effects of the drug, they're wearing eye shades, they're listening to music. And a lot of times there's not much talking going on. All the therapist is doing is helping the patient or guiding the patient, saying, let the drug, feel the effects of the drug, let it take you where it's going to take you. They're not telling you what you should talk about, what you should do. The therapist sometimes can be a little more directive, especially when during the preparation sessions there was the mindset and the intention discussion. And so there, if the therapists get a sense of what might be important topics, right, to have for the patient to come up. And then during the drug session, they may ask the patient, what's coming up for you now? What are you thinking about, right? And if the patient's talking about something completely different for, let's say 2 or 3 hours, then the therapist may say, well, during our preparation, you talked about wanting to understand your relationship with your mother better. Think about that. See where that takes you, right? So it's very non-directive. And in fact, one might say that if you had extensive training in CBT, it may be very hard for you to unlearn that, because sitting in there, you may want to kind of interject, right? But in fact, what you should do is sit back and do nothing and really let the drug take the patient where they should go, right? And again, this is not something that is regularly taught. That's not something, when people go through residency or psychology training, this is not a normal part of their training. People now are going to special programs and institutes to learn about this style, right? So the MAPS organization offers the training. It's about 100 hours. There's about 50 or it's about 60 or 70 hours that are reading, and there's some in-person component. They charge $5,000 for it. And after that, you get certified, right? Meaning that you're certified for their MAPS training. But that's not. This is not a standard part of our psychiatric training, and that's one of the reasons why there's going to be a big bottleneck. Meaning that the part that prevents widespread access is that we're not going to have enough therapists who are trained in this model to deliver it as it's been shown in these studies. And then hypnosis and so interesting. I have not seen anything where they are combining hypnosis with psychedelics, but one might actually say that psychedelic experience is very akin to a hypnotic experience. So for the MAPS training, what they used to do was actually anybody doing the training, they had an FDA approved protocol where people would actually get a little MDMA to feel what it was like. But it's too difficult to do. So what they do is holotropic breathing. Have any of you heard of that?
Yeah.
Yeah, holotropic breathing. So they use that as a surrogate for the participants to somewhat understand what it might be like to experience a non-ordinary state of consciousness. It involves almost like hyperventilation. I think you get a little bit alkalotic, and you kind of you feel different. Right, and I actually went through that training, and it's a very different experience. But I haven't seen any studies like that. But one could imagine that patients undergoing a psychedelic experience may be more suggestible to psilocybin, right, or to hypnosis. That's probably one of the reasons why the CIA was interested in using it as a mind-control brainwashing technique, right? Because patients are letting their guard down, are more suggestible. We often call psychedelics agents of change, right? So people come in with these very, very rigid ideas about themselves, about the world around them, about the relationship with the world around them. Psychedelics, some people think or propose, kind of loosen those very rigid ideas, right? You bring those walls down. And so you're able to make changes that you were not willing or able to do before, which potentially can be problematic. So during these trials, what they ask these patients to not do is, within 6 weeks of doing the treatment, do not make any major life changes, right? There's been anecdotal stories of people going into these trials and then coming out and they realize, you know what? I don't like my spouse. I don't like my husband. I don't like my wife. I don't like being a lawyer. I quit. I'm getting divorced, right? And their family members are like, whoa, right? But some of these drugs can kind of really precipitate those major life changes, right? And long term, maybe that's the right thing to do, right? Maybe that you'll be a happier person if you leave your husband, right? Or if you find another job. But generally, when people make those decisions, it's a little bit more gradual, right? Not like one day and then the next day you've quit. So that's another cautionary tale about how these drugs can affect you.
还有没有其他问题? And please allow me to add the last question.
Yes.
I'm curious about the future impact of psychedelic treatment. If it is proved, I think the treatment may be more and more common in the future. And how do you think it will influence the epidemics of like drug abuse problems in the future?
Yeah, that's a great question. So there are trials looking at it for specifically substance abuse issues. We know in patients with major psychiatric disorders such as PTSD and depression that there's higher rates of substance use disorders. And so, if we're able to get I think any treatments that get a better handle on those primary psychiatric illnesses such as depression or PTSD, I think you'll see rates of substance abuse go down. As far as you know, and in fact, back in the 50s and 60s, the best evidence or the best studies actually came out for use of psychedelics for alcohol use disorder. So that's probably where the strongest evidence actually might be. And there are ongoing studies right now, but it just so happens that the ones that are furthest along happen to be for PTSD and depression. In terms of widespread use, yeah, it's I think some people in the field hope that everybody gets access to this, but I think the reality is it's in the beginning at least it's still going to be very limited. You only have a limited number of therapists who have been trained in this model. Insurance is going to be deciding who to pay for it or not, and they're not going to pay for it for everybody who wants it. That's for sure. They're going to say, you need to try the SSRI first. You need to try the atypical antipsychotic second. You need to try mood stabilizer third. Maybe you do TMS. And then if all those things don't work, then maybe we'll pay for this, right? So yeah, it's a very interesting question about what the access is going to look like if and when this gets approved.
It's just like the pilot, he took psilocybin by himself.
Yeah.
So he has maybe some way to obtain that kind of substance.
Yeah. So these drugs are actually very easy to get, right? Even they're all illicit. You go to your drug dealer on the corner, and they can get it for you. So that's the other part about this is that some people are asking about can these drugs by themselves be helpful without the therapy, right? Which would make it actually much easier to access, right? We would prescribe it just like as we prescribe an SSRI, right? You don't need the psychotherapist, you don't need all that extra other stuff. But if you look at the real-world abuse data for MDMA and psilocybin, there's no evidence that people who abuse it recreationally have lower rates of psychiatric illness, right? If it was effective by itself, then you would probably expect that people who abuse it probably would have lower rates of depression or PTSD, but there just isn't that evidence. So, people will obtain it, but hopefully the message will be that this really needs to be done in conjunction with in the proper setting, with the proper preparation, with the proper psychotherapy for it to work. The MAPS organization, they're very clear in saying the effective ingredient in our treatment for PTSD is the therapy. The medication is just helping with that, right? So it's not the right? It's not the MDMA. It's really the therapy. It's the two combined that really kind of give you that big effect. Compass pathway is a little bit different. They're saying it's primarily the psilocybin, but you need the safety, you need the therapy to ensure the safety. So yeah, that's one of the things that people are worried about is when these get approved, people, if they can't get it through the legal means, if that, for example, their insurance companies won't pay for it, maybe they'll just go and obtain it illicitly, right? And so that's a major concern. And if there's a lot of bad outcomes, these things may be even more tightly controlled.
Okay, today Dr. Dunn gave a very excellent talk covering the historical context of psychedelics to the clinical trials. I believe everyone learned a lot from his talk today. So let's give him a big hand, okay?